Mr. Zira, Mrs. Zira, Professor Ashraf, Chairman of the Congress, Chairpersons, ladies and gentlemen, it's my pleasure to be here. And I'm going to speak about a different topic away from cardiovascular events, diabetes. I'm going to speak about osteoporosis in some of the medical disciplines we face. Now, osteoporosis came to the limelight during the last 25 years. Because of two reasons, we have more machines now to diagnose osteoporosis early because we used to rely on x-rays, and by the time we find x-ray change, the patient already has lost between 30 to 40% of his bone mass. At the same time, we have an armamentarium of drugs. We have so many drugs in the market now. We have drugs which can be taken daily, weekly, monthly, every 3 months, every 6 months, every 1 year, and we are going now through an era of biologic drugs which are coming, anticathepsin D, for example, and antisclerostin, and these are coming to the limelight soon. So how we define osteoporosis? We have two definitions. One of them by WHO, and the other one is by the National Institute of Health. Whatever the definition is, the ultimatum or what consequences take place due to a weak bone is fractures. And it is our job to prevent the first fracture, because this is fairly a silent disease which progresses, and it doesn't have any symptoms unless the patient have a severe fragility vertebral fractures which leads to sudden severe pain in the spine. But eventually, patients fracture their bones, and usually this happens when we are old because we are living longer than expected. Our bones cannot tolerate the burden of our movements every day, and so eventually, if we don't have attained a peak bone mass at adulthood, we are losing bone very frequently and very quickly, and fractures occur. And this is the cycle of bone, how it goes. We start putting on calcification of the collagen matrix of the bone, and we achieve a peak bone mass at the age of 30. And you can see that men, unfortunately, have a higher bone mass more than women, though women, they have the pregnancy and lactation and so on. And then we start losing bone by the rate of 1% every year. In females, at the age of 40 to 50, when they start their menopause, they will lose at a higher rate of 5% every year instead of 1%. And this is where we are hit very hard when we have adverse factors, and we start falling when we are old. At the same time, we are losing the sunlight, which will give us the vitamin D which we need, and this will lead to vitamin D deficiency. We are not eating proper food, we are not taking enough dietary calcium, and we fall frequently. And this is where we fracture our spine or our hips. And this is the bone structure itself. We were under the impression that we have two very important cells, the osteoblasts and the osteoclasts. The osteoclasts will start the process of bone remodeling. It will start demolishing the areas of bone which were under stress, fatigue, fractured, and cracking, and then this is followed by the osteoblasts coming to the area where the bones has been destroyed and laying on new bones. The balance between the osteoblast and the osteoclast is very important, because the amount which is destroyed by the osteoclast, it's laid again by the osteoblast. But for many reasons, where this balance is distorted, we find that the bone destruction is taking the upper hand, and the osteoblasts are not laying enough bone to compete with the increased loss by the osteoclasts. Recently, we have a very important cell which we neglected for a very long time, which is the osteocyte. These cells are called the osteocytes. And these osteocytes, its main function, they have mechanosensors or mechanoreceptors. They are interconnected together by canaliculi. And whenever a fracture occurs, a microfracture occurs, or a micro damage occurs, it will sensor to the osteoclast, and the osteoclast will go to the damaged area, the surface area, and start demolishing the bone from this area, and then the osteoblasts will come to lay new bone. This process takes almost 6 months. But the first part of it, which is destruction by the osteoclast, it takes up to 2 to 3 weeks. Now, the osteocytes are very important because they detect where the fractures or cracks occur. They produce sclerostin, they produce cathepsin D, which goes to the surface and start the process of destruction. Now we are having new drugs coming very soon, which anti-cathepsin D and at the same time anti-sclerostin. And this is how it starts. We have the osteoblasts coming to the area, and they are starting demolishing the bone, originally coming from the hematopoietic cells, followed by the osteoblasts coming from the mesenchymal cells, laying new bone. And this cycle, as I mentioned, eventually will lead to proper mineralization, taking up to 6 weeks. 6 months, sorry. Now we have many factors which affect our bone remodeling cycle. Genetic factors, and we have aging factors. But here is the vertebral fracture threshold, which is almost at the age of 50 to 60. And then between 65 and 80, this is the hip fracture threshold. We have many factors, what we call very important risk factors. Some of them are unmodifiable, like genetics, osteoporosis runs in families, the gender, the age, the family history. At the same time, we have modifiable risk factors. Inactivity is one of them. Too much sports, especially in young girls, which leads to premature menopause, obesity, state of depression, smoking, hormones, medications, and so on. So we have 2 types of osteoporosis. Primary osteoporosis, which is either postmenopausal or senile, and then secondary osteoporosis, secondary to a primary cause. Now this is an alarming thing for physicians and patients with secondary osteoporosis who will come and present with the following should alarm their physicians. Unusual fractures, the patient is fracturing very frequently. Very low bone density for their age. Recurrent fractures irrespective of adherence to anti-resorpatives and therapy. Abnormally basic laboratory tests, for example, an elevated ECR, which can mislead and the case can be originally metastatic. Unexplained bony pain, and this is usually due to vitamin D deficiency and insufficiency. Undetermined bone lesions, which can be seen on the X-rays, like metastasis, myeloma, malignant lymphomas, and so on. The problem of osteoporotic fractures is increasing, and it is worldwide. It is projected that in Asia, for example, they will reach a total of 3.5 million by 2050, and before that it was almost 1.6 million only. So we have many obstacles in the management of osteoporosis. It's a silent disease. Some of the fractures occur and pass unnoticed. There is insufficient rate of diagnosis and treatment, though we have many machines now to detect osteoporosis early. It's a challenge of persistent to therapy because most of the patients with a chronic disease, they don't stick to therapy. They don't adhere to the prescribed dose which we are giving to them. They're persistent over time, patients don't get the medications, and compliance is a very bad thing in the management of osteoporosis. We found that in Egypt, for example, the patients will stick to their treatment for 3 months only, up to 50% of the patients, and the rest will stop them after 3 months. We measure the bone mineral density by the DEXA machines, which are available now, and if the patient have an osteopenia, normal bone density, and an osteopenia between -1 to -2.5, and then definite osteoporosis, minus 2.5. Mind you that patients with osteopenia, 50% of the fractures which you come across is coming from patients who are osteopenic. And this is the curve. You just measure the bone mineral density. It's gram per square centimeter. The T-score, which is the one we are using now, it's age independent because it's the reference to the young person, while the rest score is age dependent, and we use it for measurement in the children. -1 and above, patients considered normal. Between -1 to -2.5, patient had a low bone mass. Patient is osteoporotic if it is less than -2.5, and established and severe osteoporosis, -2.5 and 1 fracture. The one exception to this is patients who are taking glucocorticoids. With glucocorticoids, if the patient had a bone mass -1.5, he's considered by being osteoporotic, and the anti-resorptive treatment should be initiated. And this is what we get here. This is we measure 3 sites. We measure the hip, we measure the spine, and we measure the forearm. What I'm going to speak about this morning are 4 disciplines: cardiology, where osteoporosis goes with cardiology, endocrinology, gastroenterology, and just touch on the metabolic syndrome. Recently, it has been shown that osteoporosis in 190 patients undergoing coronary angiography due to chest pain, 27% of them were osteoporotic, 40% was osteopenic, and 33% had a normal BMD. And 76 of those osteoporotic and 78 of those with osteopenia had obstructive coronary artery disease. And it was suggested that patients who come for angiography should also be checked for osteoporosis, especially the older age group. And at the same time, deficiency of vitamin D is associated with an increased risk of cancer in patients with cardiovascular disease. We know that vitamin D now has a new role, apart from its calcemic role in maintaining the hemostasis of calcium and phosphorus. It has what we call the pleiotropic action of vitamin D. It has an effect on the autoimmune system. It has an effect on the cancer, reduction of cancer. It has an effect on diabetes type 1 and type 2 diabetes, and cardiovascular diseases, and it's coming one of the cornerstones in management of chronic diseases. Patients who have valve disease surgery, they are giving long-term anticoagulants, and this leads them to be vulnerable to bone loss. At the same time, they are lacking mobility and physical activity. Atherosclerosis and osteoporosis are both multifactorial, related to the aging process. I'm not going to speak about the calcium this morning because I think we have a case presentation about calcium, and it will initiate a lot of discussion. This is something which I found, and I don't know what the cardiologists think of it, that finding that patients who have been taking statins, and it leads to accelerated coronary artery and artery calcification, that those patients are liable to develop diabetes, and the FDA had mandated that diabetes risk to the warning labels of statins. And the latest discovery makes it clear that statins not only carry a significant risk of developing type 2 diabetes, but they can accelerate the cardiovascular complications associated with diabetes, and I believe we should have a discussion about this in our next presentations. What about endocrinal diseases? Growth hormone deficiency, patients with long-term therapy have demonstrated improvement in the body composition. At the same time, the bone mass has increased, as well as the density and the muscle strength. Hyperthyroidism, patients with thyrotoxicosis, they have generalized osteoporosis because the bone formation is much less than the bone resorption, and the bone resorption is taking the upper hand. And the TSH causes osteoporosis due to lack of hormone and lack of proper calcification. This is one of the things I'm seeing more frequently now because we are very much aware of it. Patient with primary hyperparathyroidism. Those patients usually had adenomas, benign adenomas or carcinomas, and usually those patients were diagnosed at the beginning because they have generalized bony aches. They have been diagnosed as rheumatoid arthritis, and I'm doing now routinely to all of my patients PTH level to see how the PTH looks like. Vitamin D is another important factor because the fibroblast growth factor is very important. It decreases the bone mass because of the increased bone resorption in the tissues. Diabetes, diabetic osteopathy is due to inhibition of collagen production by the osteoblast. It impedes osteoblastic bone formation and will lead to deterioration in the bone quality. Vascular supply is disturbed to the bone due to the microangiopathy, and insulin-dependent patient had a lower bone loss already than adjusted diabetics. And just put this slide to show you the correlation between the pancreas, the kidney, and the parathyroid. And the most important players here are the parathyroid hormone, at the same time the fibroblast growth factor, which leads to acceleration of osteoporosis. Osteomyelopathy, which is degenerative change of the bone marrow, vasculature, and degenerative reaction to the bone stroma will lead to osteopenia, will decrease the rate of bone remodeling, and this will lead to increase the risk of fractures in patients with type 2 diabetes. And those patients usually fall due to other things, visual impairment due to the effect of diabetes on the eye, imbalance, peripheral neuropathy, hypotonia, and so on. Oral gastroenterology. Chronic disorders of the liver and the gastrointestinal tract, like malabsorption syndromes, are a primary cause of osteoporosis. They are secondary cause of osteoporosis, leading to a combination of osteoporosis and osteomalacia, a condition which we call osteoporomalacia, where you find that the patient is having osteoporosis and at the same time he's complaining of severe bony aches, not muscle aches or joint aches, it's bony aches. And this is due to deficiency of vitamin D in particular, K and C. Patients with Crohn's disease, the young age, they lead to sarcopenia. They have sarcopenia, which is muscle weakness due to mainly deficiency of vitamin D. You find that they are young, they cannot move properly, and their muscles are very weak. Following bariatric surgery at the same time and malabsorption and loss of calcium and improper utilization and absorption of calcium and vitamin D leads to fractures and osteoporosis, variation in external absorption. And the most important thing, most of those patients with Crohn's disease or celiac disease, we give them high dose of steroids, and autoimmune inflammatory diseases before they are associated with increased production of pro-inflammatory cytokines like TNF-alpha, and which has a deleterious effect on the bone. This is the pathophysiology of the glucocorticoid-induced osteoporosis. They have an effect on the osteocyte, they decrease its function, and they increase the apoptosis, which is programmed cell death. On the osteoblast, it decreases differentiation, function, and decreased apoptosis. This will lead to less bone formation. The bone quality is decreased, the bone mass is decreased, and the patient is at risk of developing fractures. At the same time, with the neuroendocrinal and the calcium metabolism, there is decreased calcium absorption, increased excretion, negative calcium balance, eventually leading to the decrease in the bone mass. On the muscle itself, it will lead to proteolysis of myofibrils, and we lose usually the fast-twitch type 2 muscle fibers, which prevent us from falling. They will be decreased in the myofibrils. Myopathy will occur, sarcopenia, muscle weakness, and increased risk of falling, which will lead to fracture. One of the things which occur with osteoporosis generally, that the stresses which are connecting the collagen matrix to itself, they start becoming thin, and then they become dispatched, and then eventually disappear. And this is an irreversible process because you cannot lay new collagen. But in glucocorticoid-induced osteoporosis, it reached this stage where the cross stresses are only thinned. And this is why glucocorticoid-induced osteoporosis is irreversible, more than the primary osteoporosis. This is the type of fractures we get in the spine, and this is a typical example of a fracture here. But if you go higher, you find that there's another fracture wedging occurring, and the whole texture of the bone is very osteoporotic. Professor Adil have mentioned the metabolic syndrome, so he made my task very easily. And just say there's a close relationship between the metabolic syndrome and osteoporosis, because the excessive fat, the abdominal fat, will lead to hepatic and muscular insulin resistance, leading to hyperglycemia, hyperinsulinemia, resistance to insulin, and at the same time, they are two risk factors for osteoporosis. High levels of uric acid will lead to prothrombotic state, indicating involvement of the kidney, hemopoietic systems, and interferes with the bone metabolism, leading to renal osteodystrophy. The immune system is also involved, leading to osteopenia, and the BMD and fracture risk in patients with metabolic syndrome is determined by the balance between the beneficial effects of obesity and detrimental effect of hyperglycemia. Though patients who are obese with the metabolic syndrome, they have a protective effect of the fat on the hips, and instead of giving them hip pads like we do for thin patients, when they fall, usually they don't fracture their hips. Now we can measure the bone mineral density. We can measure the amount of fat present, which is either android or gynoid, and we have here the scale to say if this patient has metabolic syndrome and its effect or not. So, chairpersons, ladies and gentlemen, I would conclude by saying that bone remodeling is a long life process in which the old bone are replaced by the new bone. Remodeling occurs in response to mechanical stresses, and osteoporosis was previously thought as a disease which is part of the normal aging process. However, it can affect any age, secondary to many risk factors. Routine DEXA or BMD measurement should be carried out in patients with chronic diseases so as to assess the development of osteoporosis and risk of fractures. And we should never overlook the fact that osteoporosis is eventually a preventable disease, and the objective of early diagnosis and treatment is to prevent the occurrence of the first fracture, and if we failed in this, at least we should try and to prevent the second fracture. Thank you very much.